So here I was really disappointed by your answer, because so many people of you answered E, when there was, why would this guy have uremic encephalopathy? See, 45-year-old male, he has sudden onset excruciating headache. Something is occurred with his head or anything. On further questioning, he has a prior history of flank pain, hematuria, and hypertension. Okay, flank pain, hematuria, and hypertension. This, from there you thought the problem is renal, and so yes, uremic, because urine has something to do with renal, right? You thought like this. She again tells, this is an important line, similar symptoms were present in his uncle, means there is some family history. Getting it? On examination, his GCS is 12 by 5, doesn't matter. When his hip joint and knee are flexed, he resists the subsequent extension of the knee. While neck is flexed, there is neck stiffness and he flexes. What are these signs called? The first one they are mentioning, that is Brudzinski sign. When the hip joint is when the hip and knee joint flex, he resists subsequent extension of knee. That is Brudzinski sign. And when the neck is flexed, there is severe neck stiffness and causes patients' hips and knees to flex. That is Kernig sign. These are the clearly signs of meningeal irritation, not meningitis. Meningitis is a type of irritation, but not meningitis. Okay, this is the sign of meningeal irritation, and during the examination, he lapses into unconsciousness. This is the data we are given. Now, whenever you have flank pain, hematuria, and hypertension in a patient, and there is a history, family history, always think of polycystic kidney disease. Okay. Yeah, uremia can happen, but that is individual. The family history is not present. So flank pain, hematuria, hypertension with family history, it is usually 99% autosomal dominant polycystic kidney disease. And PKD is not always, but usually associated with Barry aneurysm. Okay, and when this aneurysm ruptured, this caused a subarachnoid hemorrhage leading to meningeal irritation, which caused the Brudzinski and Kernig sign. Okay, so let's go to the option whichever suits us. Embolic occlusion to cerebral vessel, no, that doesn't explain our hematuria and flank pain. Increased wall tension within the aneurysm, sounds correct. Intracerebral hemorrhage, no, we said subarachnoid hemorrhage, right? Intracerebral hemorrhage doesn't cause meningeal irritation. See, meningeal irritation from space occupying lesion, yes, Barry aneurysm occupies space, but that is not a lesion. I mean, lesion is something to do with tumors and those hemorrhage expanding. But whenever there is space occupying lesion, the signs are not this sudden. It is chronically it expands. The tumor doesn't expand this slowly. And lastly, uremic encephalopathy from chronic renal disease. Whatever encephalopathy, whenever there is uremic encephalopathy, there are many other things to consider. There may be liver failure. Because see, whatever amount of ammonia is going, there should be a presence of liver failure. Because who metabolizes urea? Liver, right? Now, whatever amount of urea kidney gives to the liver has to metabolize it. But here there are no signs of liver liver damage. He is not an alcoholic. He is not an alcoholic. He has no familial history of liver disorders or SGPT, SGOT isn't given. So we can't straight away move on to uremic. That was the least. We shouldn't answer uremic encephalopathy when we aren't given anything about liver.
Thanks for watching. Please give a thumbs up and subscribe for more.